What we're going to talk about is kind of the work that we've been doing here locally and the tools that we've developed to help all of you take this great information you're getting and then bring it into your practices and to be able to carry on and do good work. I try really hard not to accept anything free from the pharmaceutical folks. It's hard. I don't know what's on my pen, but it's worth the effort. So, as was stated earlier by Andrew, this is an iatrogenic public health crisis that we're in the middle of, and importantly, we have got to own some of the responsibility for this. We are, well educated. We have authority, and we need to use it to make the kinds of changes that have been discussed today. And the reason is because we now know that the risk-benefit ratio for people with chronic pain is shifted pretty far towards the risk side, and you really need to be sure that you can support the benefits as you keep people on opioids chronically, and certainly at high MED. And you've probably seen this slide before if you've ever heard me talk. But the issue is that we have to stop playing whack-a-mole in our community. We have to embrace this together because otherwise desperate patients, patients in pain, patients who don't understand the dilemma they're in the middle of are just going to go from provider to provider, and we haven't really solved the problem, we've just kind of shifted it. So 5 years ago or so, we created what at the time we called the Opioid Prescribers group, because we thought we needed to learn how to handle opioids better, and we've now changed the name to the Oregon Pain Guidance because we recognize that opioids are often inappropriate, and it's really about how do we manage chronic pain. And many of you in this room have episodically been to the meetings. We try to bring together people who prescribe, behavioral support, substance abuse counselors, the CCOs are at the table, and various other folks will come and go. And we also video conference with, I'll go to the next slide. We video conference with Grants Pass, so it's really a Southern Oregon phenomenon. We have a steering committee that meets every 2 weeks to kind of move the work along. We get CME. We meet in this building. You get dinner. It's a pretty good deal. We meet for 2 hours every month. We've kind of evolved. In the beginning, it was like, we got a problem. What are we going to do about it? We had some of the speakers here had helped us, Skyped with us, been on the phone with us to help us kind of figure out where we're going. We had the excellent Washington State guidelines to work off of, and we eventually created our own guidelines, kind of the first iteration of this. And currently what we've been doing at the meetings is kind of a mixture of some didactic work, case presentations, and small group discussion. And we have three audiences, really, ultimately, for the work we're doing. First is the providers. And I want to say that it's really easy, especially if you're a bit isolated, to sort of not, we're all talking now like we get it. There's some people that are putting their heads down, they're doing their work, they don't have a lot of interaction, and this is brand new to them. They really haven't learned sort of what the current best practice about chronic pain are. And then there's others who frankly just don't believe it, right? They just see it as a fad. You told us this 10 years ago, and you're telling me now, and 10 years you'll be telling me you got to prescribe more, kind of like hula hoops, or the pendulum just keeps swinging. And so I think those folks need to be able to hear this message. But ultimately, to get a community to kind of do the right thing, we have the providers, and that's partly what this is about, to educate ourselves. And then the patients need to understand. If we do this in isolation, they don't know why is everybody suddenly telling me I got to get off my pills. And this is such a big problem, it affects everybody. There's someone who's got, an uncle who's out of control on pain pills, or a nephew that died of an overdose. So the entire community has to hear the message. We've been doing public education on TV. We have TV spots that run on a regular basis. Those of you that were able to attend the community forum yesterday, Michelle Maricos and others put on a phenomenal forum. There were over 300 people there from the public to talk about chronic pain and things you can do. It was kind of like a health fair. And the basic concept is if we can disseminate this concept widely, then pretty soon, everybody's going to have the same conversation, and we can kind of be on the same page. So this is our website, and you'll notice this is the landing page, and you'll see that it's divided in two, so to speak. We've got the patients and family section, and we've got the healthcare professional section. So patient and families, so it's informative. You can see that we were telling people about the community forum, the guidelines from the CDC, which I'm going to talk a bit about. You can click here and get a nightly news report sort of that can summarize it so people can digest the material. On the right, we have all sorts of upcoming events, and on the left, you've got information that we vetted and thought would be appropriate for a general audience. You can go and see videos we have, as well as some of the quick 30-second spots. We've got various animations, which I think are really actually phenomenal, and you can go all the way down to the prop videos. People can take it to the level that they want, and we have websites and other resources. So if you go back to the professional page, similar here, where we're kind of pushing this pain conference that we're at right now. So, and then the upcoming events are going to be a bit different as well, and the free training for buprenorphine's on there, et cetera. And this, you saw this slide earlier. This is that whole discussion about what's happening with Caucasians in America dying at a higher rate than they did a decade before. So if you go up here to the toolbar, I guess this is called the toolbar, you have a discussion of the Oregon Pain Guidance, and what I want to draw your attention to is the fact that these guidelines, and by the way, they were printed, the printing was finished last night. So I mean, it's always good to have a goal to move you along, and we knew the goal was to have it done by this conference. So the entire guidelines are in PDF format right here on the website. There they are, and so you can download them, you can play with them, you can make them your own, you can do whatever you like with them, but they're accessible. The other thing I want to draw your attention to is we took many of the tools that are in here, took them out, and tried to make them easy to download and print out. So, for example, you heard about the PEG 3, and so here it is in downloadable form, and we did that for as many tools as we. I actually could stop here on this, so let me do that. What I want to talk about now is are the treatment guidelines, and it's been redone. And the reason is that, number one, there's been an awful lot of work. I mean, the folks that have been presenting today, who are actually doing the research and reading the literature closely, know that this is a rapidly changing field, and what we thought we knew 3 years ago really is kind of different than now. And the second is the CDC has created a set of guidelines which I think can serve as a foundation and a backbone. I mean, we can all quibble with them. There's things that kind of left out. There's some politics involved. But in general, I think that can really be something that we can look towards. And our feeling was, we're not smarter than all those people that put that together. So we really created something that could operationalize the CDC guidelines. That is to say, hopefully you will find tools that will make it easier for you to practice medicine in the way that I think we're coming to some consensus about. We also focused on some areas that we really didn't focus appropriately on before. We really call out acute pain. We talk about pain specialty and sort of what we think that should look like. That was a fairly controversial discussion. And we call out tapering a bit more. Okay, so now, as an introduction, the reason I just wanted to start with the introduction is to sort of point out what's in the entirety of the document. So we've got the introduction, which is very useful because you've got the CDC guidelines, you have sort of a summarized axioms of care, and some basics. And then we've got treatment of acute pain, chronic pain. We talk about non-opioid options. And I'm not going to read all this because I am going to pull out a few areas to talk about. I do want to say that when we got into specialty areas, we really tried to make sure we were getting some consensus from the dentists and the ED docs and the pediatricians in terms of what would be appropriate care for those groups. Thanks. So, acute pain. I think the issue that's been brought up earlier is that we've got to pay more attention to acute pain. And my feeling is that if you're an experienced clinician, you're a dentist, and you've been doing dental extractions for 20 years, you have a pretty good idea of how much pain the average person is going to have after a dental extraction, and it may be 24 hours, it may be 36 hours, it may be 8 hours, and that's the amount of opioids you should give. If you have people that are falling off the bell-shaped curve, well, you might want to figure out why that is. And it may be because there's a complication, and it may be because they really like the opioids or they would like more. But either case, I think you need to call them back and pay some attention. So we created a flow sheet. We have 4 flow sheets that are, in your case, they're laminated. If you get them off the internet, you'd have to laminate them yourself. And I think it's key. I understand that in acute pain, things are moving pretty quick, but you still have to assess where you're at. And you still have to discuss non-opioid options, elevation, and heat or cold, and over-the-counter medicines. Those things are really very important. If you do opioids, you need to have them be appropriate for the injury, and then there's the stop and reassess. So we do the same thing with chronic pain. It discusses chronic pain, including the patients you inherit, the so-called legacy patients. And in fact, the treatment is really not that different for those two groups. What's different about the flow sheet, of course, is there's a lot more involved in the assessment and a lot more involved in ongoing monitoring. These are folks that, have got a chronic problem and need to be managed as such. We have an opioid tapering flow sheet, and we have a benzodiazepine flow sheet. And for those of you that saw the previous document, everything's a bit different, but the chronic and acute pain the flow sheets are probably pretty distinct. Can't read what it says. How many minutes? 5, thanks. Okay, so the specialty care. My feeling, in our community at least, there's lots of different folks who have different degrees of training, but have expertise in treating chronic pain. And I think that it would be appropriate for us to sort of have a sense of, if you're going to send somebody to a specialist, kind of what would best practice look like. So we have some discussion of that. Trauma-informed care, childhood trauma, PTSD, as you've heard, are really important components. So we kind of drew that out so you could understand it a bit better. And these are just some examples of some of the subsections. We talk about MAT. I don't think we had much discussion of that in the last time. Talk about disposal. marijuana. Then there's various medications that you should know about and treat with great respect. Naloxone, we spent quite a bit of time in the document on naloxone. And Laura Husacker really has done a great job of condensing some of the basics of how you have a difficult conversation, because these are difficult conversations. And those of you that are interested, you'll hear more about it this afternoon. And then there's an all-day workshop that Lee and Peter and Laura are going to be doing tomorrow in this theater. The appendices, again, we tried to isolate the tools we think you'd find most effective. This would be an example of something you could pull off the appendices. You need to know your community resources. If you're going to take this and use it in any way in your own community, I'd recommend that you find out where your community resources are. Okay, what comes next? I think you need to go back and evaluate your practice. How many chronic pain patients you have? What's the MED for them? Are you aligned with the CDC guidelines? And do you have some kind of uniform plan so that all of your patients can be kept safe? So I want to end with this. So here's where I feel like we're at in treating this problem. So that could be me, that blonde kid smiling in the middle, in 1950s in the back of a station wagon, just driving around. Who knew about seatbelts, right? You're having a great time in the car. And we had some mythology about kids and accidents, right? It's a good thing you didn't have a seatbelt on, because if you went off the cliff, you'd get thrown out of the car, and you would have gotten crushed on that rock, but now you're safe. And we just didn't know. We didn't have the data. And then pretty soon, people said, wow, it's dangerous for kids to be in a car just rattling around in there. And so they created seatbelts, and you put seatbelts on kids, and the data started coming in. That is really important to keep kids safe. Right. So there you are. Mom says, got to run to the store. Come on, get on your seatbelts. And you go, I'm not doing it. You can't make me get on the seatbelts. I won't. Okay. Just this time, we'll just run to the store and come back. But the next time, you're going to put on your seatbelt. Right. We were ambivalent about it. It hadn't sunk in. We weren't fully engaged. We kind of knew it was a good idea. Okay, now that's where we're at. Does anybody here leave the driveway without their kid in a seatbelt? You absolutely do not. And it doesn't matter. They could throw the world's biggest tantrum. You just got to put them in a seatbelt. It's safe. You know it's safe. It's in here. And there were some laws that came along that helped you do the right thing. But in general, it was all about safety, and you know it's about safety. We're not quite there yet with opioids. We need to get there. And I'm sure that if everybody in this audience knew it was around safety, and that person's there and they're just crying, and you got to help me, and you don't understand, my life's a wreck, you can't take my pills away. And if you say, I know it's not safe for you, I think you can do the right thing, and we're trying to provide tools for you to do it. Thank you.